something about Dr. Mohty. He's a professor of hematology, head of hematology and cellular therapy department at Saint Antoine and Sorbonne University. He is the past president of the BMT, and he is the editor-in-chief of the bone marrow transplantation journal. His talk is going to focus on what is the latest in CAR T cell therapy and bispecifics for multiple myeloma. The second speaker is Dr. Majed Alahmadi, who is a consultant in adult hematology and bone marrow transplant at Princess Noura Oncology Center, King Abdulaziz Medical City, Jeddah. And he will talk about how I treat IMID refractory multiple myeloma. So without any further ado, I'll ask Dr. Mohty to go ahead. The screen is yours, Dr. Mohty.
Thank you very much, Dr. Ayman. Assalamu alaikum. It's really a great pleasure and an honor to be with you tonight. Although I would have preferred to visit you in person. Every time I go to the kingdom, it's like, you know, getting some barakah from the Holy Land. So we're missing this, but hopefully the good time will come back and we will be able to meet again. So thank you for the invitation. And you have asked me for the next few minutes or so to speak probably about one of the hottest topic, I would say, in the field of myeloma, namely immunotherapy, whether CAR T cells or bispecific. It's a pity because ASH will be starting in a couple of days. I cannot give you in advance the results of some, you know, or the updated results of some of the trials, but I'll give you a selection of what you would expect from ASH at the end of my talk. These are my disclosures. So just, I think for the younger colleagues in the audience, to highlight immunotherapy. So immunotherapy is a very broad concept. I think people who are doing solid tumors and oncology are very familiar with the active immunotherapy, for instance, immune oncology, immune checkpoint inhibitors, dendritic cell vaccines, peptide vaccinations. When you use cytokines, interferons, also IMIDs, these are active. Then you have the passive immunotherapy, and this is where, for instance, you're using monoclonal antibodies, and we know very well, for instance, in myeloma, that the anti-CD38 monoclonal antibodies, daratumumab or isatuximab, have been really a breakthrough in the field. But you can also use passive adoptive cellular therapy as a form of immune therapy. And this is where the CAR T cells are going to fit. So just a brief reminder, because I'm not sure everybody's familiar with the technology. The idea is to redirect the TCR towards a specific tumor antigen. Then you will be able to overcome the HLA restriction. Remember, when we do allogenic stem cell transplantation, actually we do sort of a soup of cells, and we don't overcome or we don't redirect, we don't have a targeted approach. And the idea is here indeed to induce an adequate number of high affinity T cells. It's like you have an army, but then you equip all the soldiers with a very specific weapon, which is very precise and can really hit the enemy. So in multiple myeloma, for the time being, when it comes to CAR T cells, the antigen that has been considered as the most attractive for CAR T cells is the BCMA, B cell maturation antigen, because it's highly and widely expressed on the malignant plasma cells. And one important feature when you would like to identify an antigen for CAR T cells, it needs to be a safe antigen, which means you should avoid side or side effects on normal tissues. And this is why BCMA is attractive, because the BCMA knockout mice are actually healthy. So this is really good news. I think the first convincing study about the value of CAR T cells in multiple myeloma came from China, actually, maybe 3 or 4 years ago. This is a so-called LEGEND-2 study, and they have used it in the so-called refractory myeloma. But obviously in China, patients have less access to drugs than in our countries, in the US or Europe. So these were not heavily pretreated patients, in my opinion. Nevertheless, they managed to achieve a relatively impressive rate of CR, and including MRD negativity. And when you look to the median duration of response, this was more than 2 years, which is really very good in an environment where they didn't have access to novel drugs. And also, these patients responded very quickly. The median time to initial response was around 1.1 months. And in contrast to CAR T cells in ALL or lymphoma, actually the rate of adverse events was rather mild. And you can see the PFS, but also the overall survival curve. So these were patients who were treated in China. And actually, there was a similar study, but in the US, with more heavily pretreated patients, actually median of 6 lines of therapy. And this is the so-called CARTITUDE-1, because the product from Nanjing, the Legend Car T Cell construct, was both acquired by Janssen in the US, and they call it now JNG4528. And they run this phase 1b/2 study, and actually it will be updated at the next ASH, so in 3 or 4 days, so you will have to watch for it. Nevertheless, what I can tell you is that in the initial presentation at ASCO and at EHA, the results were really impressive. Although the patient had 6 median line of therapy, including very high-risk patient, penta-refractory, triple-refractory, actually, these patients have more than 95% objective response rate. And again, the duration of response was quite very good for a population who received 6 lines of therapy. Another important message, the safety profile was rather good when it comes to the cytokine release syndrome and neurotoxicity. And we know that these are the 2 main side effects with CAR T cells. And it looks like, because this is true for all products with CAR T cells in myeloma, it looks like that myeloma is less, I would say, less subject to severe CRS or neurotoxicity. The second, so we hope that in the next few months, this JNG product will get some approval or authorization. The other product, which is also advanced, and it's ready, I think, for approval or authorization by the drug agencies, is this famous BB2121. So this is Celgene Bms. And initially, this product, this study, phase 1, was published in the New England Journal of Medicine by Nupur Raj from Boston. And you can see the patient received a median of 7 prior lines of treatment. And again, during this ASH in 3 days, you will see an update about the 65 or 67 patients that were treated, because these were the first 33 patients. And you can see that these were patients who were exposed to the proteasome inhibitors, the first in class, bortezomib, the second generation proteasome inhibitor, carfilzomib, which we know is highly effective in myeloma in general, was a first line or refractory, but also they were exposed to lenalidomide, pomalidomide, but also daratumumab. So you would imagine really a difficult to treat population. And this BB2121 construct, which we call IDE cell, and actually I lost my slides. I don't know what happened. Maybe I can ask the technical colleagues to go back to my slides. I didn't do anything. They have just disappeared spontaneously. Now this is the case of Dr. Alahmadi, I think. How to get back to my slides. Okay, here we are. Thank you, Mr. Talat. So this BB2121 actually was validated in a very large trial, phase 2 multi-center international. This is the KARMA so-called study, and now BB2121 is called ID cell or IDE cell. And actually, these patients received a median of 6 lines of therapy. Some patients received, up to 18 lines, and you can see very nice response rate, including CR and stringent CR. When you look to the progression-free survival, we are around 9 months. You may think this is low, but remember, these are patients who are really end stage. They have failed everything. They are supposed to go to palliative care. So clearly, this is very attractive, very interesting. And actually, again, when you look to the incidence of side effects, CRS, neurotoxicity, definitely this is something manageable and good to handle. So this KARMA study, which is the largest one, actually is going to help, I think, to the first approval of a CAR T cell product in multiple myeloma. To be fair, there are other coming products. So actually the landscape is quite crowded. And actually in China, for instance, you have a dozen of in-house CAR T cells, and they would rather do CAR T cells to many patients earlier than some of the drugs, because in China the CAR T cells can be cheaper than buying IMIDs or other drugs. So to be fair, there is another product called Orva-cel. This is the Evolve trial, and again, I will not spend a lot of time simply to say they all work. And to be honest, I don't know for the moment whether there is one product better than another. All of them looks to be working actually in these patients. But actually, the crucial issue when it comes to CAR T cells, whether in myeloma or ALL or lymphoma, actually is about the persistence. And this is where we need to be humble for the moment. Why these patients are not cured, why we don't see a plateau, probably because we are not able to allow the long-term persistence of these cells. And that brings me to the fact how to overcome the mechanism of resistance when it comes to CAR T cell. Because I personally believe that all the CAR T cells that are being tested are available, have shown as a proof of concept that they can work. We're taking patients with a median of 6, 7, 5 lines of treatment, and you're showing more than 90% response, including CR. You're showing 12 months or 10 months or 11 months of PFS. So definitely they work. The question is, how can we further improve this efficacy to achieve results similar to ALL and non-Hodgkin lymphoma, where you have 30 or 40% of the patients who go on a plateau, so maybe cured, and we have now long-term survivors. So the mechanism of resistance to CAR T cells in multiple myeloma are very subtle. It can be due to the CAR T cells themselves, intrinsic. It can be due simply to the malignant plasma cells, but we also know the microenvironment can create an immunosuppressive situation. One way of going through this is, for instance, trying to produce fitter CAR T cells. So playing on the product, because we know that for the moment we're doing an apheresis and we're taking all the lymphocyte, but we don't know whether these are the right soldiers. The second part, we know that in some patients, and you will see during the next ASH meeting, there is a lovely presentation by Dr. Nikhil Munshi showing, and this is publicly available on the title and in the abstract, showing that you can lose BCMA, and you can even lose the gene by itself with a mutation. So one aspect is about using a simultaneous targeting of another antigen, so a sort of a double security. And you will see at ASH, there are now other CAR T cells with other antigens being produced. You can also act on the microenvironment, and I believe trying to immune modulate the microenvironment, and there may be some opportunities to combine these CAR T cells, especially after infusion, with the available drugs like IMID, for instance, or even checkpoint inhibitors, but also antibodies, because an antibody like daratumumab, for instance, we know that it allows to delete, the immunosuppressive environment. Obviously, I don't think we should do daratumumab after CAR T cells, because the CAR T cells can express CD38. So you don't want to kill your CAR T cells. We need to be careful. But having something before can be extremely powerful. And also, I think we all know that checkpoint inhibitors that are used in oncology didn't prove to be highly effective in myeloma, and they have some safety issues. However, maybe we can use these checkpoint inhibitors after infusion of CAR T cells to favor, the expansion of the CAR T cells. And of course, one other way of doing things is to do these so-called armored CAR T cells. So you can equip the CAR T cell where, when it is infused in situ, it can itself, for instance, secrete whatever cytokine, to overcome the immunosuppressive environment. So I think, I hope you are convinced that CAR T cell approaches in myeloma are highly attractive. For me, these are really impressive results, although patients continue to relapse. We obviously still need to improve efficacy and, for instance, humanized construct, targeting double antigens, how to allow these antigens, how to allow these CAR T cells to better proliferate. This is why we have to work on the product. I didn't allude to this, but obviously, as you may guess, the cost of the CAR T cells can be a problem. We're talking about something around $500,000 for an infusion. So the ratio of cost, efficacy, and safety need to be assessed, because for the time being, we do not have a sort of a pharmacoeconomic evaluation of all this. So for the last couple of minutes, if you are preparing your agenda for ASH, actually, I did a selection for you. So for instance, and I put the number of the abstract, the time. Don't forget, this is the time, 7 a.m. San Diego time. So 7 a.m. Plus 9, this is 4 p.m. in Paris, and this is going to be 2 hours later in Saudi Arabia. So be careful, guys. So actually, it will be difficult for you and for me to follow all the ASH unless we stay awake all night, and listen, because they have used specific times. So you will see an update of this CARTITUDE-1 trial, really including quality of life. So this is really important, and we were missing, but we will have also data about the side effects. BB 2021, I'm trying to be fair with everybody, so I'm not favoring one or another. So you will see the presentation by Nina Shah, by Yi Lin. This one is really a very nice presentation. And of course, you will see quality of life data from the KARMA study. There are many subgroup analysis, and I think we need to see this because you have the extramedullary disease, the high-risk cytogenetics, and I'm looking forward to this one about healthcare resource utilization, because then you can evaluate what is the real cost, because the cost of a treatment is not only about the drug, it's everything you do. And if patients go to intensive care, it's important to assess this cost. As I mentioned, we will see more product. For instance, this is an interesting novel generation BB2121. It's called BB2121-7. And I'm looking forward to this. I don't know, I'm not aware of these results. But as I mentioned, there are other BCMA CAR product that will be presented, and we'll see how these products. I mentioned the capacity to have a dual targeting, and actually it's already being tested. I believe this is an abstract from China targeting both BCMA and CD19. And one of the most exciting one I have seen, and I'm looking forward to it, is the Allergenic Car T Cell. And there is a phase 1 data about this product, ALLO-715. And why I'm insisting on the allergenic, because obviously the problem with the autologous CAR T cells is that it takes several weeks, of manufacturing. Whereas if you have allergenic CAR T cell, they are just off the shelf. It's like any drug, you prescribe it, and 1 hour later or half an hour later, you can give it to the patient. So this is important when you're talking about relapse refractory patient. So with this, I'd like to thank you all for your attention, and I'm happy to take your questions, but I think this is going to be after Dr. Alahmadi presentation. Thank you very much.
Thank you, Dr. Mohty, for this elegant presentation as usual. Now it's time to hear from Dr. Majed Alahmadi about how to treat multiple myeloma, especially in this very difficult subgroup, which are IMID refractory patients. Dr. Majed, screen is yours.
Okay.
I would like to draw the attention of the audience. Please post your questions in the Q&A section, and then we'll come to that at the end. Go ahead, Dr. Majed.
Okay, so thanks for the SSBMT for inviting me. So today it's going to be a challenge talking after Prof. Mohty and also after a very attractive topic in the field of myeloma, CAR T cell. So people are like, oh, your talk has been used before, but Prof. Mohty has a very interesting new topic. So I will try to make it interactive a little bit. So I will start with a real case. So this is one of my patients, unfortunate one. So he is a 50-year-old, a very pleasant gentleman who was medically free, presented to ER beginning of 2017 with severe pelvic pain radiating to the left leg, causing inability of walking. So picture of coda equina, and his initial labs showed high calcium of 3.3, creatinine of 450, and very high total protein. So his CT showed this very huge mass that, destroying almost all of his iliac bone, 16 by 16 centimeter. So we took a biopsy from that, and it was a plasma cell neoplasm. And this mass was causing, compression on the nerve roots at the sacral plexus, causing coda symptoms. His SPEP showed M protein of 70 gram, IgG kappa with the abnormal kappa lambda ratio, kappa of 1000, lambda of 5. His bone marrow was very difficult to be done because bones were quite fragile, but we had 5% clonal plasma cells, although it was very diluted. His initial FISH was from the bone marrow, which, as I said, was diluted, was normal. So he received pulse dex initially, and then he received 1 cycle of VCD, and had improvement clinically and also biochemically with the normalization of the calcium and creatinine. So then, since his kidney function started to improve, we switched his therapy to VRD, received 3 more cycles, and at that time he was in BGPR. So he underwent stem cell collection, 2 more cycles of VRD, which is our usual protocol, and then autologous stem cell transplant at August 2017. And he had a radiological assessment which showed the residual mass at the iliac bone. So we gave him consolidative radiation post-transplant. Then started on LEN maintenance, but the patient was not compliant to it. Part of it, he did not like it, and also causing some diarrhea and other things. So in March 2019, so less than 1.5 years from his transplant, he started to have biochemical and chemical relapse with increase in his M protein from 1 gram to 8 grams with development of new skeletal lesion. His bone marrow at that time showed plasma cells of 50% with, again, normal FISH. So since he was not compliant to the lenalidomide, it was difficult to label him as a lenalidomide refractory. So we started him on salvage DRD, received 2 cycles, but unfortunately there was no much of a response. So therapy was switched to DVD, and he responded initially, but his response did not last for long, was only for 4 months, and then he had again biochemical progression with development of new bony lesions. So switched him to KPD. And again, he responded initially, and after 3 cycles, he presented with lower limb weakness and sensory level, and MRI showed a new lesion at the level of T11 with evidence of cord compression. So he, so basically he is progressing on that. So basically, this patient had pulse steroid and urgent radiation with clinical response. So far, he is someone refractory to bortezomib, lenalidomide, daratumumab, carfilzomib, pomalidomide. So this is actually the kind of patient that every myeloma treating physician would hate. So we don't have a CAR T cell available. So I talked to him about this, but he preferred not to go because some logistical issues. So started on bendamustine, thalidomide, dexa, received 2 cycles with no response clinically or biochemically, and development of more lytic lesions and soft tissue masses at the sacral area. So unfortunately, this patient did not do well and managed with palliative approach until he passed away in June 2020. So this is the problem with myeloma. Despite all of the new modalities of therapy, we reach always to a closed door. So PFS has improved, survival has improved, but we always deal with refractory patients, okay, as the time go. And the problem with that, we are losing patients. So from the first line to the second line to the third line, you are losing more patients. And as we can see here from this diagram, that patients who are double refractory to lenalidomide and bortezomib, they don't do quite well based on some of the analysis that has been reported. And all of that is related to the clonal tithing theory, where you have one dominant clone, you suppress that, and underneath that there are more resistant non-dominant clone that will become more dominant with different drug sensitivity. So lenalidomide in multiple myeloma is becoming a standard of care in first-line therapy in many centers, incorporated in multiple regimens, VRD, KRD, sometimes RD, DRD. And we know the data from multiple big randomized trials showing the efficacy of lenalidomide. For example, DRD in transplant setting in the IFM 2009, which showed an outstanding results, as well as the SWOG trial for VRD in non-transplant setting, and also showed an excellent PFS. For the transplant ineligible, we all know about the first trial comparing RD with other regimens, and it showed the efficacy of PFS, and also the Maya trial, which shows also a very excellent results in terms of PFS with addition of lenalidomide. And for many, almost all the myeloma treating centers, lenalidomide is the first line in terms of maintenance therapy based on randomized trial data. So what I'm trying to say here, that having a patient who is lenalidomide refractory is not uncommon, and we face that a lot, and it's a very important clinical question that we face it in every day practice. So how does the lenalidomide work? So it's one of the E3 ubiquitin ligase complex, and basically it works on the the cereblon is an E3 ubiquitin ligase complex, which is targeted by lenalidomide. So that leads to enhancement of binding of specific substrates that will enhance the ubiquitization of the substrates and eventually proteasomal destruction. And also has different other approaches when it comes to managing myeloma specifically. Sorry, it's not moving. Okay, so how does the resistance happen? So it's mainly related to down-regulation of the cereblon or cereblon gene mutation. This is the most important mechanism of resistance when it comes to lenalidomide resistance. So what to do in these settings? So what the interesting thing, there is no consensus about what to do for lenalidomide refractory patients. So there is no one approach, there is no single recipe. And first of all, what's the definition of lenalidomide refractoriness? So also that's an area of debate. But according to most of the clinical trials, it's defined it as progression while or within 60 days from the last exposure to lenalidomide. But there are important questions that you have to consider. So what kind of progression we are dealing with? Is it biochemical or clinical? What was the risk status of the patient when he presented? What was the dose of the lenalidomide when the patient had this progression? So for symptomatic relapse, it's highly recommended that you have to do immediate class switch. So you consider the patient as len refractory and move to something else. But for biochemical progression, it depends on the race of the relapse, the risk status of the patient, and the dose of the lenalidomide. And you might consider You might consider going with a full dose if the settings allow you with addition of dexamethasone or cyclophosphamide, if that also can be done. So you have to look at the pace of the relapse and also the other factors related to the disease. And also you have to think about your patients in terms of age, frailty, comorbidity, and all of these to determine what's the best approach for these patients. So in terms of what to do, so there are multiple options can be used for these patients. Most of them is either bortezomib or proteasome inhibitor based, for example, bortezomib or carfilzomib based with addition of monoclonal antibodies. Or using the second or the third generation IMID, which is pomalidomide. So the Castor study, we all know about it. So comparing DVD versus VD, and that showed excellent results with the long-term follow-up, significant improvement in the PFS from 26 comparison to 7.9 months. And what about with these refractory patients? We can see here the difference was still there with 10.3 months in patients who are refractory with addition of DARA to VD in that group of patients. And also we can see here the depth of the response. We are getting more CR, and even we are getting more MRD negativity with the addition of daratumumab to backbone of VD. The Endover, on the other hand, looked at carfilzomib dexamethasone versus bortezomib dexamethasone in relapsed refractory setting. And same thing showed a significant PFS difference, 18.7 months versus 9.4 months. And in terms of the survival, there was also some survival benefit of more than 7.6 months when we looked with the use of carfilzomib. And also the same thing, deeper responses with the carfilzomib in comparison to bortezomib, more CRs and more VGPR or better. What about in the patients who are LEN exposed? So the same thing. It showed that addition of carfilzomib resulted in better PFS in that group of patients who are LEN exposed previously. So that's one of the options can be used. The Candor study, on the other hand, compared the KD, which we were talking about just now, to addition of DARA to that regimen, so day KD. And it's important to mention that about a third of the patients enrolled in this trial were LEN refractory. So that's our topic of interest today. And the study showed an improvement of the PFS in the arm of day KD, so not reach, were 15.8 in the KD arms. And the benefit of addition of DARA to backbone of KD was noted in all subgroup analysis of interest, our group of interest, which is the LEN refractory, and we can see here addition of DARA to backbone of KD resulted in improvement of outcomes. And we can see here in this table the improvement of the PFS regardless to the previous lines of exposure. In terms of the safety, also when we look at the LEN exposed or LEN refractory patients, there was no signal of problems with safety with addition of DARA to backbone of KD. But all of us know that this regimen might be difficult in terms of convenience, because the patient has to come twice weekly and spend some time in the hospital. So there was abstract presented in the most recent ASCO comparing the data from the Candor trial to the phase 1B trial, which is also published in Blood, MMY1001. In that paper, the carfilzomib was used once weekly in term, not like what's in the Candor, which is twice weekly. And in that analysis, there was no difference in terms of efficacy when they looked at the difference between the twice weekly versus once weekly DKD. And we look at also, we have to look at the follow-up. So it was 23.5 versus 16.8, and there was no signal of disadvantage. And in terms of the safety, also in terms of the adverse events, there was no signal of worsening adverse events with the once weekly, and in fact, it was more safer as we can see here from these numbers. So, any other regimens? Yes. So the third generation IMID can be used, the pomalidomide. So in the MM003, they compared between PD versus high dose Dex in patients who are double refractory to bortezomib and lenalidomide. And you can see here from this table that most of the patients were len refractory, so our group of interest. And in terms of outcomes was dismal, because we all know that these group of patients, they don't do very well. So 4 versus 1.9 months. Can we do that? Can we do any better? So in this table, more ways of how to use pomalidomide in these settings. So with the addition of bortezomib, with the addition of carfilzomib, with the addition of ixazomib, daratumumab, and elotuzumab, and we can see here some improvement in the PFS with these combinations. And last but not least, the Liquis trial, which showed also some promising efficacy with the addition of daratumumab to PomDex, with median PFS of almost 10 months, with deep responses, as we can see here. So basically, that group of patients are quite challenging. You have to choose wisely. There is no one single regimen. You have to look at your patient, look at his disease status, and based on that, decide which way to go. But usually, triplet is better than doublet in general. I hope that was useful, and thank you so much again.
Overview about these difficult patients and how they are treated. And I totally agree with you. It's very difficult to treat such patients with whatever available. I mean, even if you use other regimens, the median PFS doesn't really cross 10 months or 12 months. So now we'll have a discussion session. Since we don't have any questions so far, is Dr. Mohty with us? I guess. I don't see him here, but he must be somewhere. Dr. Mohty? Anyhow, yeah, maybe he's trying to open up. Yes, Dr. Mohty. All right, thank you. It's just a question. I mean, you have elegantly shown all the new trials and the different CAR T cells tried in multiple myeloma. And we can see that the median really PFS is not the best as we expect from such an expensive therapy. How about, I mean, the drug conjugates or the BiTE molecules? Especially Amgen has developed these two BiTE molecules, and they are developing more, the AMG 701, as you know, which are ready to use, way less expensive than using a CAR T cell, combining anti-BCMA with anti-CD3. How do you compare that to CAR T cell therapy currently?
Yeah, so thank you. This is really a very important, but I would say this is the $1 billion question, because, of course, everybody in the field of myeloma is trying to answer this question. So let me slightly disagree with you about the price issue, because obviously the BiTE antibodies, the bispecific, actually, we should call them, will be used continuously. And I'm not sure that the price will be lower than the CAR T cell, but that's another story. I'm not an expert in drug pricing. I think, first of all, my comment, I think you're a little bit very tough with the efficacy of the CAR T cell, because you say the efficacy is not what we would expect. Can I kindly ask all the colleagues?
Comparing it to the lymphoma, for example, diffuse
Yes,
large
yes, yes.
lymphoma.
No, but I think we have to compare things that are comparable. I mean, we cannot compare myeloma to lymphoma. What do we expect without CAR T cell in a multiple myeloma patient who failed 6 lines of therapy? Lenalidomide, pomalidomide, daratumumab, bortezomib, carfilzomib, and maybe whatever else. What is the survival we expect? The survival we expect is less than 3 months. Okay? And now you're getting 10 months. I agree with you, there's no plateau. So this is, I think, the key question. And I highlighted why there is no, some of the speculations why we don't see a plateau. Now, your question, which is really very important, is about how does this compare to other BCMA agent, like the drug conjugate, belantamab, but also other bispecific antibodies. And you mentioned a nice one, the AMG 701, which will be updated at the next ASH, by the way. I didn't mention it because initially I thought that I will have a 1-hour talk. So I wanted to include bispecific and CAR T cells, but then I've been told it's only 20 minutes. So I needed to make a choice. So yeah, I think you are right. The bispecific, because of being off the shelf, because of the simplicity and availability, they will be used probably, in my opinion, before the CAR T cells. But okay, you simply delay the lines of therapy. But also, we should not forget, now we're talking about refractory myeloma. But just imagine that we have a trial, for instance, if you imagine a trial of giving one single shot of CAR T cell consolidation after auto transplant, frontline, and then achieve MRD negativity and doing nothing. So these are, I think, the future. Like in any cancer, the development is starting and will be done in end stage, but progressively we will move the lines upward, I think.
Yes, I agree with you. I mean, it's only time that will tell where are we going, but we know for a fact that CAR T cell therapy is promising in different cancers, including multiple myeloma. There is a question that I will publish from Mohamad al-Makari to Professor Mohty. Has any study been done to use biological recovery of multiple myeloma cells, i.e. resistance against CAR T, to use these pathways as hits upfront?
I don't know. I'm not sure I understand the question. I mean, I mentioned there will be a talk by Nikhil Munshi from the Dana-Farber, where they have looked into some patient who failed CAR T cells against BCMA, and they could show a disappearance and a mutation on the alleles of the genes coding for BCMA. So maybe this is one answer to the question. I'm not sure I understood.
He means that is there any targets in the myeloma cells, in the plasma cells, that we can target before even or after giving CAR T cell that will probably decrease the resistance of these plasma cells to CAR T cell therapy? This is, I guess, what was the question.
Yeah. So no, this is very important question. So this is what I alluded, for instance, using daratumumab, where you can get rid or favor or decrease the immunosuppressive environment, for instance. This is one way of doing it. Actually, you can also do a non-specific targeting. For instance, the lymphopenia after autotransplant, after chemotherapy, is a very good environment to allow the proliferation of the CAR T cells. So there are many options, and for the moment, we are still in early stage.
All right, Dr. Majed, there is a question for you by, again, Makadi. He's the one asking questions tonight, which is good. Is there a rule for using older regimens in these patients who are Len refractory, hopefully targeting IMID refractory clones? And I would add, such as, for example, the $1 pill, melphalan, for example. What do you think?
Well, I don't think so, because for most of these patients, they already has been exposed to alkylators, okay? And I'm not sure if re-challenging them with alkylators back will add much, like what happened with my patients here. So even I tried conventional chemotherapy like bendamustine, which has, alkylator and purine analog kind of effect, and I could not get any response at all. There are some, experiences about using conventional chemo, especially for patients who had a true extramedullary disease, that these group of patients might benefit from some intensive kind of chemotherapy. But I think you all agree that by the time we reach to that level with these patients, they are quite fragile, and maybe they are unable to tolerate aggressive conventional chemotherapy.
I agree with you. Dr. Mohty, any addition to the question?
No, I think it's a sort of a hopeless situation, unfortunately. In theory, we know that the chemotherapy, the alkylating agent, are good drugs, but when you try to use them end stage, the bone marrow reserve of these patients is already over, I would say. So, and for instance, there is a sort of a new generation alkylating agent, melflufen, which is a peptide conjugate similar to melphalan, but without the side effects. But then the problem is that if you develop it at 6th or 7th line, actually the problem is about cytopenia, because they don't have any valid bone marrow when you have received many lines of treatment. So it is still, I agree with you. I think Dr. Alahmadi has summarized it very nicely after his clinical case, showing that we progress, we have advances step by step, but we're always reaching a sort of a last step, which is where, you have a dead end. This is good news, because I don't know if you have seen this week, there is this Lancet Hematology paper, an update from Italy about a 10-year follow-up of just giving VTD, very basic, the first generation treatment, auto-transplant and consolidation. The PFS at 10 years is 34%, and the overall survival at 10 years is 60%. So I think we are gaining space and survival, but every time we are blocked in a refractory situation. But we should keep on trying.
I agree with you. There is a question from Professor Asker. After thanking you, is there an age limit for CAR T cell therapy?
Short answer is no. For instance, in lymphoma, we have considered patient age 80 for CAR T cell. So it's like the same evaluation for allogenic stem cell transplant, where you have to look for comorbidities, but simply you have to keep in mind that you're looking only to short-term toxicities, like to 1 month. So at the end of the day, the crucial parameter is to imagine that they will develop a severe CRS, cytokine release syndrome. And the question you have to ask, if they are candidate to CAR T cell, if they have a severe CRS and go to ICU, do we think they will survive? And actually, we have a lot of patients between 70 and 80 where we didn't have any big issue with this. The problem with allogenic stem cell transplant is that you have more long-term side effects. So the problem of immunosuppression, the problem of GVHD, etc., makes it more difficult. But in general, there is some overlap in terms of evaluation of comorbidities for CAR T cell and for allogenic.
There is probably one last question we can take. We still have 1 minute from Dr. Ihab Alahmadi. At which point in the patient journey should we intervene with CAR T cell therapy so that we achieve the best possible outcome? This is another $1 million question.
Yeah, I think this is a very good question, but the good news in this group and in the attendees that we are all believers in science and evidence-based medicine. So if you want to answer this question, you have to do the trials. And these trials are either ongoing or being planned. For instance, I showed you the CARTITUDE-1 trial with this J&G product, CAR T cell. But actually, you have the CARTITUDE-2, CARTITUDE-3, CARTITUDE-4, and CARTITUDE-5 trials. And each of these trials is asking the question about the role of CAR T cell in a very well-defined position in the treatment journey. And then we'll get the answer. I can personally speculate that probably we will move earlier because they are attractive as a consolidation, a single-shot treatment. But I may be wrong. I don't know.
Well, I guess you're right. I mean, at the end, we'll have it maybe incorporated in first line. You never know. So I said the last question, but I saw a question from Dr. Bassem al-Bairuti, and I don't have the guts not to publish it. It seems patients who relapse after IMID, they don't do well. There are data suggesting that IMID may enhance TP53 mutation, and this is a very bad abnormality associated with poor outcome. Do you think avoiding IMID is in favor of our patients? This is, I don't know. Yes, Dr. Majed, do you have an answer? Would you avoid IMID just because of the notion that these IMIDs may down the road, trigger a TP53 mutation?
Well, my answer would be no. I would like, we all know that there is a hint of secondary primary malignancies in all IMIDs, which might be related, I think, to some changes in the DNA structure, something like that, something we don't know about. But has that been proven? And this idea about increasing the TP53, we all know that there is clonal evolution that happen in myeloma patients, regardless what their therapy they have received. And these related to the clonal tidying philosophy. So, and as Dr. Ayman said that, and Prof. Mohty, that we are all believer of evidence-based medicine. And I think if there is a data to show that there is more of TP53 patients in IMID exposed more than the one who are not exposed to, I would, take that, or think about that, idea. And I totally respect Dr. Bassem for sure. He's,
yeah, he's just probably asking it just to stimulate discussion.
Yes,
but I'm
I know.
sure.
Always Dr. Bassem, all
Yes,
of his
Dr.
questions
Mohty,
are very
Dr. Mohty, you
interesting.
have
Yes,
something to say.
First of all, a special hello to Dr. Bassem. I'm missing you, Dr. Bassem. I think there are two parameters in Dr. Bassem's question. First aspect, because it's about the wording, in English of the question, but you have to, it's a little bit a long question. But first of all, I think Dr. Bassem is right that IMIDs are not the best drugs in TP53 and deletion 17p in general. And when you look to the forest plot of the studies which have used, for instance, lenalidomide for maintenance, actually, these are not the best drugs. Having said this, we believe that IMIDs in general are, and we prefer in the high-risk cytogenetics like deletion 17p and TP53 to use proteasome inhibitors. And the best drugs I know are bortezomib and, of course, carfilzomib. These are the most potent in the high-risk cytogenetics. Now, the question is, can we get rid of IMIDs? I think they are the backbone of any treatment. For me, and Dr. Majed alluded to this story of second primary malignancies, but I think this is a relatively small proportion, and the benefit is always superior to this putative risk. And but it exists, of course. I think the story for me is not about avoiding IMID to avoid whatever resistance. It's about what can I combine with IMID. Let me give you an example. When you take the deletion 17p patient, TP53, which are really the bad patient, actually the best results that I have seen published in the literature are the series from Sagar-Lonial at Emory, where they have given VRD, bortezomib, lenalidomide, dexamethasone, continuously to these patients. And these are really the best results in deletion, which highlight that actually you have to combine. So whenever in these high-risk cytogenetics, I would never use a single agent, for instance.
All right, thank you very much. We are at least 5 minutes past our time. I would like to deeply thank Professor Mohty for his presentation and the interesting discussion we had. Dr. Majed Alahmadi, thank you very much. And at the end, I would like also to thank the sponsor of the meeting, Amgen. And this is our next webinar, which is going to be after ASH at 12 December. Totally something different from myeloma. It's about aplastic anemia. Thank you very much, everybody, and good night for now.
Thank you.